Hi there, my name is Will Niven. I'm a consultant in emergency medicine, and I'd like to talk to you about the critical appraisal of randomized controlled trials and therapeutic papers. So you might start by asking the question, well, what has the randomized controlled trial ever done for us? It's a good question. And I think the best response to that is a quote by Sibold in 1998, who said that really the randomized controlled trial still represents the best method we have at our disposal to establish cause-effect relations between treatment and outcome. And what I'd like to do in this little presentation is basically take you through some of the basics of appraising a therapy and a randomized controlled trial. And we'd start off with the simple question of, is this valid? Is it true? Secondly, is it actually important? Are these findings going to make a difference to the way that we practice? And then thirdly, is it really applicable to the context within which I work? So starting with the question of validity, I like to use the analogy of the witches of Macbeth. There are really three things which can undermine the validity of a study. Results may be affected by chance, i.e. due to a random error, and we reduce this by increasing the sample size. The results may be affected by bias, in other words, a systematic error, and we reduce this by having a robust methodology. And the results may be misinterpreted and ascribed to one factor when another factor, a confounder, was actually responsible. So, for example, if you look at drowning in children and sale of ice creams, there's a definite correlation, but it doesn't mean that eating ice cream leads to drowning. Both are just more common in summertime. And you address confounding by ensuring randomization to distribute confounders equally between the two groups. Now, the consort statement was a research tool developed to help authors improve the reporting of randomized controlled trials using checklists and flow diagrams. And hopefully, with the adoption of consort, there are fewer methodological flaws in RCTs than we've seen previously. So moving on from here, you should really ask the question of whether you should read the paper at all. And two of the main questions to ask are, is the study actually asking a clearly focused question? And if it's a randomized controlled trial, is it actually appropriately so? And the two sub-questions to ask there are, why was the study carried out as a randomized controlled trial in the first place? Because not all studies actually should be carried out as randomized controlled trials. And was it the right research approach for the question actually being asked? So provided that your answers to those are yes, we would then move on to the methodology section, where the following will be of interest to you. So firstly, how were the patients actually recruited? Was this a highly select bunch of patients that was recruited, or did you just take the next patient that came through the door, otherwise known as consecutive eligibility? Were patients randomized to various groups? And if they were randomized, was their allocation to those groups actually concealed? Was there blinding? In other words, were the patients blinded? Were the clinicians blinded that were performing the test or carrying out the intervention? And were researchers blinded? Were there any objective outcomes that were measured? What was the primary and what was the secondary outcome? What was follow-up like? What percentage of patients followed up? Was there an intention to treat analysis performed, which we will describe further in further detail later on? And were there any measures of effectiveness used? And these are things like absolute and relative risk reduction and number needed to treat. So your methodology is really your main course when it comes to appraising randomized controlled trials. If you're not into meat, I've given you halloumi as another alternative. And for the purposes of our discussion on randomized controlled trials, I'm going to use the following paper throughout the rest of the talk. So let's start with the recruitment process. You really want to know how patients were recruited and where from. If you're only recruiting patients to a therapy study that are highly selected, such as the effect of a new chemo agent on patients in a quaternary hospital with a rare genetic variation of ductal breast CA, then this will obviously limit the generalizability of the study. In our case, this study was carried out in 2 urban emergency departments and looked at adults and kids. So this is a relatively common and generalizable context. Next, you need to look at the eligibility criteria, and if the researchers have strict inclusion criteria and a whole load of exclusion criteria, then this will really limit the this will limit the patient groups who might benefit from the new therapy. In this particular study, there were quite a few exclusion criteria, so any lacerations that were on the face, any lacerations that were contaminated, were all actually left out, and all the lacerations that were non-linear. So actually a large percentage of lacerations that we would encounter in our day-to-day practice. And then the last thing you want to see is that there's actually been some form of consent. So on the right-hand side over there, if you just pause the video, you can have a quick gander at what the inclusion and exclusion criteria were, and now we'll move on. The purpose of randomization is really to ensure that the two groups are as similar as possible, and that the only difference is the treatment that they have been randomized to. Bias can result if patients, carers, or researchers can influence the allocation. For example, patients may choose a treatment that they think will be beneficial, and researchers could allocate treatments to the patient that they think would do better on studied therapy. The more that patients, carers, and researchers can influence allocation to treatment group, the greater the bias that is likely to arise, and this bias is known as allocation or selection bias. So allocation concealment ensures that you protect the randomization process. And the way to do this is to ensure that the participants are irreversibly enrolled into the trial before you allocate them one of the treatments. Otherwise, the researcher could still potentially exert undue influence over the treatment allocation. So, to take the example from our paper, if the clinician or researcher repairing the lacerations thought some patient wounds more amenable to absorbable sutures, but was not enrolling patients into the trial prior to randomization, then there'd really be nothing stopping them from only observing the randomization sequence and enrolling patients as and when they thought absorbable or non-absorbable sutures were more appropriate. The ideal method to achieve allocation concealment is the telephone randomization hotline, where the randomization is actually held at a separate location that must be telephoned after a patient is recruited. The allocated treatment group is only revealed when all the patient's details have been recorded and they're irreversibly entered into the trial. So let's kind of see what they did in this study, where they used envelopes. So they said, using a random number generator in blocks of 10, the names of the suture types were placed by an independent physician in sealed, consecutively numbered envelopes. After identifying an eligible patient and obtaining informed consent and assent, the physician who enrolled the patient picked an envelope. So we can see from over here that they've made an attempt to conceal the allocation, but this assumes that the patient was honest. There really would be nothing preventing the clinician from opening that envelope prior to enrollment and deciding if they wanted to proceed based upon the suture material that had been allocated. A quick word on block randomization. Say you had 20 subjects and you wanted 10 subjects in each arm, or which is sometimes referred to as the seed. You can then have blocks in which you have an equal number of treatments in the block of 4 or of 8, but the order in which they appear in the blocks is different. So you could have BBAA or AABB, BAAB, or even ABBA. Blinding is really important because essentially you want to make sure that the patients, carers, and researchers don't actually know what treatment has been given. And what that does is that it protects the randomization sequence after allocation. There's a potential for a lack of blinding to lead to bias depending on the outcome that's actually measured. So blinding of healthcare providers is important to prevent performance bias, which can occur if additional therapeutic interventions are provided or sought preferentially by trial participants in one of the comparison groups. Blinding of those analyzing the data prevents observer ascertainment or assessment bias, and this kind of bias arises if the knowledge of a patient's assignment influences the process of outcome assessment. And the blinding of patients is important because knowledge of group assignment may influence response to treatment. Patients who know they've been assigned to receive the new treatment may have favorable expectations or increased anxiety. Patients assigned to standard treatment may feel discriminated against or reassured. The use of placebo controls coupled with blinding of patients is intended to prevent bias resulting from non-specific effects associated with receiving the intervention, and this is known as the placebo effect. Blinding is not always possible. So if we look at our paper over here, we can see that the plastic surgeons who eventually rated the quality of the scar were blinded. However, in this case, it was not possible to blind the clinicians to the type of suture material that was used in order to repair the lacerations in the first case. This statement on the right-hand side also talks about outcomes. Outcomes can be primary or secondary, and essentially what they are, the measures chosen to assess the impact of the interventions that we've performed. And what we want to see is that they're explicit and relevant. Ideally, they should be measured consistently throughout the trial. And what we don't want to see is the outcome changing halfway through the trial, because this should alert your suspicion that the original outcome wasn't providing the information or the kind of results that the researchers originally wanted. Secondary outcomes add granularity to the primary outcome, and in this case, the secondary outcome was train tracking, so something that's actually relevant to the patient and relevant to the cosmesis of the scar. So now we're moving on to sample size, and what this has done is really to mitigate against chance, and it reduces the chance of you making a type 2 error where you say there's no difference between the treatment and placebo when in fact there is one. Obviously, the larger the sample size that you use, the more likely you are to find a difference between the two treatments, and power calculations are made to determine sample size in randomized controlled trials. I won't go into the specific calculation of how you do a power calculation, but the areas highlighted in red are the information that you need in order to make a power calculation. So you need to know something about the standard deviation of the measurements. You need to set your type 1 threshold, which is generally 0.05. You need to have something about the power that you are going to use. It's generally set at 90 or at 80%, and that's 1 minus the type 2 error. And then you need your minimal clinically important difference, and in this case they've set it as a 13 millimeter difference. You want all your patients to be followed up, and they should be followed up and have their outcomes measured at a number of different times. You also want to know how many were lost to follow-up, and if over time there was a difference in follow-up between the two groups. And this brings us on to intention to treat analysis. And intention to treat analysis means that patients are analysed in the group to which they were originally randomised, regardless of whether they actually received the treatment they were allocated to. It ensures that the protection from bias created by allocation concealment is maintained. If patients are allowed to leave the group to which they were analysed, this will introduce bias. Patients who withdraw, do not attend follow-up, fail to comply, or have to change treatment because of adverse effects will be different from those who complete their treatment as allocated. Therefore, all patients should be analysed in the group that they were originally allocated to, regardless of the treatment that they ultimately received. So now we're moving on to the results section. We've talked about validity. Results really tell you whether or not this is clinically important, and from there flows the applicability of the study to your clinical practice. At the start of the results section, what you want to see is a diagram or a flow chart that shows how patients were recruited and how they flowed through the various arms of the study. And then generally you will have a table with demographics, which will show kind of any systematic differences between the groups that were analysed in each arm. In our paper, this is the headline result. So the difference between the two scores was 0.5 millimeters, and then they've put a confidence interval in there as well. And what you can see is that the lower limit of the confidence interval is minus 12.1, and the minimal clinically important difference that we talked about earlier was 13 millimeters. So based upon this result, it would suggest that there's no difference between using Proline or Vicryl Rapide for the repair of these particular types of lacerations. Measures of effectiveness indicate how much better one treatment is than the other. These are the three statistics which you'd like to see in a therapeutic paper. Absolute risk reduction is defined as the control event rate minus the experimental event rate, and that's basically a simple subtraction. So if 20 out of 100 die in one group and 15 out of 100 die in the new treatment group, that's an absolute risk reduction of 0.05, and if you times that by 100, you get 5%. Relative risk reduction is really the difference in outcome rate between the treatment and controls divided by the outcome rate in controls. So if 15 out of 100 die in one group and in the new group, and 20 out of 100 die in the control, then you subtract 15 from 20 and divide by 20, and you get a statistic of 0.25, which then gives you a percentage of 25%. So this gives you a good measure of the strength of the effect. It looks more impressive, and as a result is loved by industry. Now, the number needed to treat is really 1 divided by the absolute risk reduction. So the absolute risk reduction was 0.05, so 1 divided by 0.05 is 20. So we need to treat 20 patients in order to avoid 1 death. And this is a good way of communicating treatment effect to patients, but ideally we should also include the number needed to harm. Now, in the analysis and discussion, things can often end up as a bit of a waffle, but there's been an attempt to remedy this by providing a bit of structure, and it should really work as follows. There should be the key findings mentioned, possible explanation for the results, a comparison with the relevant findings from other published studies which may have been referred to in the introduction, limitations, and then crucially, whether or not the result is clinically important as opposed to statistically significant. In our study, there was a high dropout rate of 30%, and the longer the laceration was, the more likely it was that the patient would drop out. So we don't really have much data for the larger lacerations. And they've also crucially said that the complication rate was 11% in wounds repaired by Vicryl Rapide, and only 3% in the Prolene group. But because they weren't powered to detect difference in complication rates, they can't say that there was any statistically significant difference. But certainly if I was looking at that, I would say that it does appear that the absorbable sutures tend to have a higher complication rate. So we've talked about validity, we've talked about clinical importance, and now we need to talk about the applicability. Earlier on, I've mentioned the 4 B's of implementation. So what is the burden of the problem? Is this something that we counter fairly commonly in daily practice? And I would say yes. We see a fair number of lacerations in our day-to-day practice. Budgets, it's £53 for 12 Vicryl sutures and £28 for 12 nylon filaments. So the absorbable sutures are certainly more expensive. People hold certain beliefs about the way to do things, and you might find that given new information, some of the clinicians don't particularly want to change. So you need to identify what those barriers are. And then the other thing that's always important is really what the impact on the patient is. So as you can see over here, it's more expensive to use absorbable sutures, but if it meant fewer visits for suture removal, then that obviously is going to have a positive impact on the patient because they don't have to follow up, and you've got less money being spent in terms of clinician time. I think it's worth talking about the problems with randomized controlled trials. For a start, they're not always powered to detect all outcomes. So tranexamic acid has been shown to be of benefit in major trauma, but recent, as yet unpublished research suggests that there's an increased thrombotic rate, in those who've received it, something that should be obvious but wasn't really the focus of the original CRASH 3 study. They're often incredibly expensive, so the money that often comes from industry who have their own agenda and probable conflicts of interest. They take a very long time to perform, and this makes researchers more keen to find significant and useful findings, and the findings are often overturned a few years later, up to 50%. There are also charlatans out there that have either obvious or concealed conflicts of interest, as in the case of Andrew Wakefield and the MMR debacle. Nevertheless, randomized controlled trials do remain the gold standard, and our ability to appraise them and thoughtfully apply them to our practice is vital in our ability to provide the best care for our patients. I hope this has been useful, and all that remains to be done now is to read the paper I've sent on for discussion and the face-to-face day. Good luck.